Hello, hello. Good evening. This is Dr. V from the Georgia office. So for my 40 plus beautiful people out there, and for the almost 40 and in either direction, sending a lot of love. So today I'm just gonna grab a few cases. That's usually what I do anyway, and discuss issues that are pertinent to the low ovarian reserve group and the 40 plus crowd. So I'm going to talk about. Uh, it just happened to be that I've had two cases today I had to discuss where patients develop large cysts on the ovaries and they can't start their cycles. So there is a protocol that is going around. Actually, it's been going around for a while. And even though I usually recommend trying to do fresh on the 40 plus, if your AMH is close to one, like one of my patients' situation is, there is a Provera protocol. Okay, so for those of you that don't know what that is, it's medroxyprogesterone. It is an altered progesterone derivative. It is used in gynecology quite a bit. And so you can be on Provera prior to even starting your IVF. That should get rid of those cysts and those lead follicles. And then you can go ahead and start the injectables while being on the Provera. The Provera, it takes the role of the cetrotide or ganirelix or the antagonist. And then the only downside to that protocol, even though it seems to have very good results in terms of allowing those ovaries to grow evenly, is that you cannot do a fresh transfer because it will have that progesterone effect on the lining, so it will not match the embryo. But like I said, I had two patients today. One of them got 2 cycles canceled for she is 40 with an AMH of 0.9, and she wants to do hyperovulation and IUI, so artificial insemination. And then her last two cycles were canceled because she's developing this large cyst. The one cycle was on the left ovary, the other one was on the right. So it was like a 5 centimeter large cyst, looks like a fluid collection. Why do we cancel the cycles when we have that, especially if there's elevations in the baseline estrogen? Because they're estrogen producing cysts. And it makes the whole process of stimulating your ovaries a lot harder. So with her, she is going to opt for being on Provera for 15 days, returning to check on things, potentially be on Provera 30 days total, and then going ahead and starting her cycle for IVF this time. Okay. The other subject that I wanted to talk, because I had this happen today, low ovarian reserve in conjunction with endometriosis. I have discussed this before in the past, that it is better to do embryo banking. Endometriosis patients should ideally not prime with human growth hormone because it will make the endometriosis potentially grow. So we're priming with other things, including supplements and BRP. And then she's going to do 3 IVF cycles back to back to back. So, IVF period, IVF period, IVF period. And then we're going to do loop run for 30 to 60 days with the add-back therapy, and then start transfers. In my experience, that seems to work very well. And the problem is borderline AMH with endometriosis. It's kind of a very fine line between trying to get rid of endometriosis and at the same time not suppressing the ovaries too much that we lose any potential eggs. But for endometriosis, please try to do, especially with that combo of endometriosis and borderline ovarian reserve, try to bank embryos. Then work on the pelvis to cool it off, potentially laparoscopy at any point with either Orlisa or Lupron suppression to cool off any microscopic endometriosis inflammation that could be on that pelvis. And then the other case is I have a 46-year-old, and she actually does fairly well. She has an AMH of 1.5, which is fantastic for her age, and she is still making, eggs with her IVF. So we're going to try to do really mini IVF with her on this cycle to try to see if we can improve the quality of her eggs. The first few cycles that she did, she wanted to do PGT testing, which in general we do not recommend. Okay, we don't recommend testing the embryos, especially in that age group, because it's better to transfer early and it's better to transfer fresh. Older eggs are not bad necessarily, but they're more frail. So you want to keep them in the body, the majority of the time. So the least amount of time outside of the body is best. But one thing that we did notice on her PGT cycles is that if she made more eggs, she had less normal or mosaics. And so on her last PGT cycle, all of her embryos were abnormal. I think that she will go for no PGT this time, and we're really going to slow her down with a very mini, like 75 letrozole cycle. So slow and gentle, give her time to create whatever amount of eggs, but give those eggs time to do cell division in a gentler way. Okay, more is not always, it's not always better. Okay, so let's see. We have some questions here. Is it a requirement to have varicella vaccine prior to FET? No, actually, varicella vaccine. Ideally, any vaccination that you want to do, just go ahead and get it out of the way prior to doing any fertility treatment. So if you're going to do varicella vaccine prior to FET, then I would do it, then wait 30 days prior to your transfer, but it is not a requirement. I'm 40, my transfer was October, 2 embryos, 3AA, fresh. How much is the percentage of success probability in the 40 plus crowd without taking into consideration your AMH and your particular biological age? I would say it's less than 10%. But that doesn't mean that you can't be on that 10%. After transfer, so a lot of people ask me if it's normal to have pain or bleeding after transfer. You can have a little bit of spotting right after transfer from the manipulation. That does not mean a miscarriage. You can have some mental cramp. Actually, it's called implantation pain. It happens even in spontaneous pregnancies. That's why a lot of women don't figure out right away that they're pregnant, because right about the time that they're going to get their periods, they're going to feel a little crampy, like their period is kind of coming, but it doesn't come, and it's actually implantation pain and not period pain. Okay. So another question I had earlier concerning the vaccine along the same line was the MMR, the rubella measles vaccine. And again, in general, we recommend that if you're going to get vaccinated, you do it, way ahead of time, or you take a break to take care of your vaccines and then restart your fertility journey 30 days after last vaccine. Okay. I did PRP last month for FET and it failed. Should I do it again this month for FET? So Celeste, actually, if you have stage 4 endo, you are exactly the type of patient I was discussing earlier. I would encourage you to Make sure you have a good amount of embryos, depending on your scenario, 8, 10 embryos kind of banked up. And then I would work on your uterus. So yes, I would do PRP. I would do certain supplements to cause anti-inflammation. And then I would consider doing, in your case with the stage 4, I would consider doing either Lupron or Lisa for 2 months at least. My Midway A2 and progesterone was 217 and 33. That's good. Your Midway Labs don't tell us a lot. So it is not indicative that you are pregnant, and that whichever way, whether it's an IUI, spontaneous time intercourse, or a transfer, the way we do, the reason that we do Midway Labs is that we could correct deficiencies prior to potential miscarriages. And in the same 3 scenario, time intercourse, IUI, or embryo transfer, we can have hormone deficiency. There is something called luteal phase defect, for example, where women, they don't know they're getting pregnant. The only thing they realize is that they cannot get pregnant. And when we really look closely, it's just that they're not making enough progesterone to support a pregnancy. So that is the reason that we do those labs, so we have time to correct it before it becomes an issue. But they look good. I mean, your Midway labs look good. So what prenatals do you recommend? I like a few companies. The one that CNY recommends, Molecular Fertility, is a good brand. I like Garden of Life. I like Nutritional Frontiers. I like a prenatal that either is food-based or it has a food buffer. It's funny, I had a lecture today about this. And why is that? Because we are designed to absorb our nutrients from food, because they come in complexes. If you take the vitamin E complex, for example, and you look at synthetic vitamins, it says alpha tocopherol vitamin E, and that is actually kind of incorrect. There's 4 different variations to tocopherol, and it is a vitamin E complex associated with selenium in the middle. So it's like a little complex thing. And you look at all vitamins are about the same. Like, for example, vitamin C is not really ascorbic acid. Ascorbic acid is actually the outer portion of the vitamin C complex. So isolated synthetic vitamins, at first, they might make you feel a little good, but then eventually they're going to cause certain deficiencies in your body. So I always recommend food-based, or that it has a food buffer, such that if there's any vitamin isolates, the food that's in the vitamin is going to provide the cofactors for that vitamin complex to work well. All right. Okay. All right. Well, very good. Thank you all for being tonight with me. Tomorrow morning, we will recap with the Spanish crowd early on in the morning. And then I will see you guys next week on Wednesday. Every Wednesday, or almost every Wednesday night around this time, I will pop up for your questions, particularly around the 40+ crowd / decreased ovarian reserve patients. So may you all be blessed and have an amazing weekend. Bye-bye.